Welcome to the United Leukodystrophy Foundation, uh, our ambassador meetings for webinars. And I would like to welcome here our guest speaker is Christina Schnell, and she has a wealth of knowledge that she's going to share with us. Uh, and her wealth of knowledge comes twofold. She is a community services coordinator with St. John Ambulance, and that's here in Ontario, Canada, as well as she is a mother, which gives us a lot of definitely a lot of knowledge. But she's a mother of two children, and one of them is special needs with a rare disease, and we all know rare disease well in our community. Hers is SMA. So with that, she's going to talk about first aid and CPR and how to do that with our community of, the things that we tend to be associating with leukodystrophies, which would be seizures, choking, easy like falls, cuts, and stuff like that. So, without further ado, I will hand it over to Christina. And oh, by the way, Christina, maybe you can mention whether or not you want questions during or wait till the end, and I will let you decide that since you're the presenter.
Well, I did look, and there's not very many of us. So if you guys want to ask questions as we go along, that's okay. Or if you're the crowd that would like to wait to the end, I am fine either way. And then sometimes it's easier as we're going along, and then we can kind of just stay on that kind of topic. The whole kind of deal was I did put a slideshow together with lots of things in mind. But again, I'm always up for like self-guided tours as well. That's okay. Yeah. So I'll start to share my screen. Okay, so this is what you guys put up as for today's chat. So that's that. I just kind of wanted to start off with that. I wasn't sure how much you were going to share. Um, and then is it switching? No, it doesn't look. Oh, hang on a second here. Let's go this way. Okay. Yeah, so a little bit about me. Um, I started my fire career a little later in life because I wanted to make sure that my kids were well looked after. So this is Natalie. Natalie is 26. She has spinal muscular atrophy, which is a neuromuscular deteriorating disease. So what Natalie has is basically ALS in children. So with ALS, they have generally, when diagnosed, a 2 to 5 year life expectancy. With spinal muscular atrophy, depending on the later you're diagnosed, the longer your life expectancy. So when Natalie was diagnosed, she was diagnosed at 2 years old. And they told us that her life expectancy was kind of in her 20s. Now, obviously, that's changed in the last 26 years with science, which has been great. They do have a treatment now. And so, as a mom and a first responder, that's also had to do some choking first aid on this child here. It's also been an eye opener for me as well. So we do have some key terms here. So I am in Ontario, Canada. So I do have to do a little bit of a disclaimer that what happens here in Ontario is not going to be the same everywhere as per regulations. The idea kind of stays the same, but you do have to remember that it is kind of a discretion of your governing body as to how your first aid is done and shared and its regulations. So most of these are going to be Ontario, Canada, either sayings or most of the things that we have released from our governing body. So this one itself, obviously, the World Health Organization. Health is a state of clean physical, mental, and social well-being. And this is one of the things I did say to Marla was obviously after 26 years of having a child with different abilities. It's not just about how to make it through those things, but also how we look after ourselves. So, for first aid defiances and rules here in Ontario, Canada, mostly this slideshow is made for. Our ages are for an adult between the ages of over the age of 8. And a child is between 1 and 8 years old, and an infant is under the age of 1. This is a physical chart. This is obviously not a mental chart. So when you're giving back blows or compressions, etc., this is the age range that we're kind of going with. Okay, so physical, because I was reading a little bit about what you guys are dealing with. And, it's the same as every child. Natalie's 26 years old, but I think she only weighs 120 pounds, right? So again, depending on your size will affect all the other things we're going to talk about shortly. Okay. So our objectives are that we want to make sure that we're preserving life, preventing any further injury, and promoting recovery. So some of these things, obviously, I'm going to guess and say most people here are kind of like the main caregivers. Is that kind of what I'm getting as a gist? Yeah. Right. So obviously that's our main priority is to preserve life because these people are very important to us. We do want the things that we do, we want to make sure that we're doing them correctly and we're preventing any further injury. And I say that because compressions can be done wrong and we can cause damage. And there are side effects to when we don't do first aid correctly. Right. And then again, this job is back to us. Promoting recovery is usually for the casualty, but I think that in most of our situations, we are the ones that are making sure that um, whatever recovery looks like, whether it's a band aid or an antiseptic or um, you know, care right down to stitches after, like surgery after stitches, etc. Okay. So, when we look at the first aid world and we notice something abnormal, we notice that something has changed. What we're looking for are signs and symptoms. So, something is a sign. So, it's like a stop sign. It's something that we see, or, something here where you can measure. So, the stop sign. So, you look at them and we know these people very well where you're kind of like, oh, you kind of look a little off today. And those are the things that we can start to monitor, right? Symptoms where the things that they know something is happening, but necessarily we can't see them. They're hot or they're cold. Maybe they feel nauseous, have a headache, things that they have to tell us. So the signs and symptoms. So whether we see it or it's something that they continue us to say, we want to make sure that these are the things that lead us to the next steps of first aid. Okay. When we look at our people, and as a first responder and also as a mom, these are our children, our family members, etc. But they're also when, I don't know if you guys have any gatherings, you all seem to be very far apart in distance, but um making sure that if somebody seems a little off, everybody goes right to unconscious. Everybody just believes that this is just an unconscious set of rules, but it's not. How is their airway? Are they breathing? The average adult breathes about 12 to 20 times a minute. And so they say on average, you can say about 7 words between taking each breath, but I think that maybe I'm, a little above and beyond, and I could probably go about 15. But if they're not getting out 7 words in between those breaths, then we're starting to know that there might be a problem. And we can start to look at all these other things. So their breathing, are they struggling? Is it regular, abnormal? Okay. And their circulation. So we're looking at their skin condition, their color, their temperature, and then if we have to go on to a rapid body survey. So generally, these are the rules. Um, whether they're conscious or unconscious. And a lot of the world just believes like there's one or the other. It doesn't seem to be any semi-conscious, right? When we go up to people or we get a call and we appear as the medical team, you start to do your look on the way in. How do they look? Once you get there, start asking them simple questions like, what's your name? Do you know where you are? So then they're going to start to talk to you, and are they comprehending what you're saying? Do they know who they are or where they might be? Okay. So those are our conscious or semi conscious rules to if they can understand where we're going. Now, these rules also fall into like if you come across a casualty or you come into the room and they're not answering you. We as parents, we've all done it. We stand at the doorway and we all like, you listen for the breathing. Can you see the breathing? Is it normal rhythm, or does it seem a little off? If you're not feeling like it is, and you have to, you can, we do talk about tipping the head back and opening the airway, because the tongue can fall to the back of the throat. So we do want to make sure that we head tilt, chin lift, open the airway. Can you hear them breathing? Can you now see them breathing and look for those signs? And generally, it's about 5 to 10 seconds. Your circulation, are they of regular color, too hot, too cold? Depending on, like, um, I'm when my daughter was still able to move a little bit, she would fall out of bed, a toddler bed, so not very high, and then you'd find her in the middle of the bedroom floor, and you just stand there and you do all of these things because she's now sleeping on the floor. But if you're not seeing these signs and symptoms, do you have to move on and call for help? So I don't know how far everybody is from medical help, where Wendy was just talking about moving up to beautiful 40 acres up on the hill. So I'm pretty lucky. We live very close to the paramedic station if we do have to call. However, if your casualty care or your family member, you're not getting the help that you need right away, um, people can still hear you when they're unconscious. So we always want to reassure the casualty help is on the way. We're constantly rechecking their airway, their breathing, their circulation, um, making sure that we cover them with a blanket and reduce any shock. I know it says record your findings. This is mostly for um, people who don't know you or medical help is taking too long. Sometimes it's okay. Sometimes people do document those things, and record those findings. Like it has been useful before. It does show things like heart rate is up or breathing has dropped, etc., in order to um, we do get a little, I would say a little flustered. Sometimes they are kids, and that's when shock kind of steps in. Making sure that if we are waiting too long for medical help, that when they get there, we can give them a little bit of a report. Okay. So we'll start off with some choking. This is our new and updated um, what's the word I'm looking for? Protocols. So um, this is brand new into the video. I took some screenshots of the video because I want to go through it slower than the video actually goes through it, only because I have had to do this before. But so for when our family members are choking. It does occur when the airway is blocked, but it's not always fully and completely blocked. It could be a partial blockage, can't breathe, can't speak, like or they can do some of those things. I remember about I don't know, 15 years ago, my son probably would have been 4 or 5. So Natalie does have a younger brother, Wyatt. He is now 19. So I remember being in the shower and him coming knocking on the door and telling me that Natalie was coughing and she did have a partial blockage. She was actually choking on the fat of a piece of bacon. So she has done this to me a few times. So mild choking, they can. She was still making some noise. When I got there, she was trying to dislodge the food by herself, whereas it can go into severe choking, complete blockage, cannot speak or breathe. The universal sign of choking is supposed to be your two hands around your throat. Um, Again, she was quite young. I'm not sure if she quite knew did like her brother, but her brother knew the signs and symptoms of the way she was coughing to go get help. So, first aid for choking, if it is a mild choking, we generally encourage the casualty to cough and try and clear their own airway before we step in. Now, there are some times that we will step in. It could use some assistance sometimes. So we do want to encourage them. Try and get them to clear their own airway because the more we step in, obviously, the more harm we can cause. Because we are giving 5 back blows followed by 5 abdominal thrusts, and some of that will change, and we're going to talk about that. Obviously, these are two very well able-bodied people here in this picture, and so he, has got his arms around her. He's given her 5 back blows and 5 abdominal thrusts. So here's the thing about, when we do 5 back blows is that we wanna make sure that we are supporting the front of our casualty. We never, ever, ever want to do something unsupported or like, and I'm sure people have heard this before, like, we don't want to do compressions for CPR on a couch or in a bed because what's happening is the couch, the cushions, etc. You need a solid surface. So when this gentleman here in the picture goes to give 5 back blows, you want to make sure I'm going to practice on a pillow here. You're going to want to make sure that you pull that person in to give 5 back blows. But we definitely, I see that. And when I teach teenagers too, they're so cute because they put their hand on someone and they're just like, they they want to do the job, but you want to also make sure it's effective. So when he goes to turn those back blows, you definitely have to support your casualty as well. So, this is, our brand new video. It's made me so happy because, obviously, we've never taught this sort of stuff before. This is a whole new section, um, about a casualty who uses a wheelchair. So our casualty here in the wheelchair is struggling a little bit. And, so the first aider here has decided that they are going to help. And so, a casualty that's in a wheelchair should only be removed if they're very definitely struggling, or you have to get them out because you have to start CPR. Okay. So this casualty is in a manual wheelchair. I know for myself, my daughter is in a power wheelchair. So they're taking this wheelchair, and if they're like, so if they go unresponsive, that's when we would take them out. But if they are still responsive, they are recommending that you put the wheelchair against a wall or somewhere firm because we do know this. Manual wheelchairs are pretty light, and we don't want to be giving somebody thrusts from the front and knock the wheelchair over. So she's going to put her against the wall, and she's going to make sure that she's putting the brakes on. The thing about here is my daughter is in a power wheelchair. So, manual chair, you want to make sure it's against the wall and the brakes are on. If it is a power wheelchair, you want to make sure that it is off so that you don't run yourself over, which has probably happened. People have probably been run over a time or two. Okay. So we're leaving them in the chair. If you're unable to deliver abdominal or chest thrusts, you're going to just go right to the front, put on the brakes if you can. This chair is low enough that they are able to give back blows while still in the chair. If you don't have that luxury or it's not supported, we definitely need to go straight to front compressions. How does this chat work? Um, just to clarify, I do have a chat, just a second. just for clarity guidance here in the UK, is that after each back blow, thrust, the first aider checks to see if the obstruction has been dislodged rather than doing 5 back blows. Okay, so if you're so that you're hoping that your casualty when you're doing 5 back blows, um, see how they have her leaning forward and supported. We're really hoping that if it dislodges, it will come out of the mouth. Until we see it, you're gonna do the 5 and then change to the front. Hang on a second here. Okay. So, okay, supporting them as they lean forward. Okay. If we cannot, we are going to deliver 5 chest fronts from the front, similar to CPR. Now, this is where rules kind of change as per wheelchair. I'm not going to lie. So this casualty has to be supported from the back with one hand doing chest compressions at the front because they have no headrest. Some of our kids or family members, my daughter has a headrest. So she is supported at all times sitting backwards or like sitting, like leaning backwards. So she can lean into the chest and I don't have to wrap my hand around her. This video, I kind of wish that they did ask somebody that had a kid in a wheelchair or somebody in a wheelchair how it's actually happened because I've actually done it. So with Natalie, and it will vary again depending on the wheelchair, is that back in the day, I was like, so in the video, they show you one hand, one fist, and they pull in and up. I was actually able to do that with Natalie in reverse. So one hand or one fist, one hand, and I could push in and up. Natalie recently in the last year has had a little bit of a tough go, and now is on her 5th feeding tube because they're messing things up. So with Natalie, we would have to change to the 5 chest thrust from the front. So instead of in and up on an abdominal or going the opposite way, going in and up. So the description to this would be like you're trying to get the air out of the stomach and the lungs to dislodge whatever is stuck, right? So whether if you can get from the back and do hand, fist, hand, in and up, or you're doing it the opposite way, fist, hand, push and up, because this way you're pulling, this way you're pushing. With this one, she has no headrest. So again, modified arm around and trying to push on the chest. You're trying to basically try and knock the wind so that it dislodges. Now, if they had a headrest, you would be able to do a push from the front up in the chest. The other thing that abdominal thrust doesn't work for is if your casualty is pregnant, because all you're doing is doing a thrust on a pregnant stomach. Okay,
Yeah, I just
so yeah,
mentioned something when we've had to do the maneuver several times with our son Aiden, who is 27 now. And back in the time before these new rules, it was never taught when I would take first aid before how to do anything in a wheelchair. And Aiden he's in a power chair now full time, but when we were having to do the maneuvers, he was in a manual chair. And we would just wrap our arms around him and the chair and do the abdominal thrusts.
yes.
Um, After several times of needing to do that, he now has a G tube, but he still likes to eat a lot of food orally. So that's interesting. Now with the G tube, thankfully, touch wood, we have not had to do a maneuver. With the G tube, we'll have to definitely do that
Yeah,
chest.
so you have to move up to the chest. Yeah.
Right.
Yeah, so that's one of the things that we too, we have not, since Natalie has had her feeding tube placed, we have been lucky enough, we haven't had to do any, she's pretty much just a nibbler eater now, she doesn't eat a whole lot. So we haven't had to do that, but that would obviously have to be modified. Um, I like when you have that manual chair and you're lucky enough to be able to wrap all the way around that if you have long enough arms. Unfortunately, her wheelchair has gotten bigger and it's almost like my arms have gotten shorter and everything is definitely, lean forward, 5 back blows, but also some of the other modifications also as well would have to be, Natalie is on a $1 million SMA drug right now. And at one point, she was very much losing control of her head. It was too heavy. She would have to use her fingers to put her head back up. And so we're back to like as if, and we're going to talk about this when we get to the infant section, it was almost like you have to support in order to, I'm sorry, everybody wants to come visit. Um, Almost like you have to do that head support in order to, um, keep them safe as well. So there are a lot of, adjustments that you would have to make, right? So when our casualty is in a wheelchair, we don't want to remove them unless they're unresponsive. We want to perform 5 back blows if you're able, depending on the size of the chair and the size of the casualty. You can do your abdominal thrust or your chest thrust, but make sure you deliver your chest thrust, if you can from the front. But again, that's going to depend on your casualty. Okay. So modified, right? So 5 back blows, 5 chest thrusts. You're repeating until the obstruction is relieved or your casualty goes unconscious. So what you're really hoping is that this is the only thing that you have to do. You want to make sure that this is where your first aider is behind your casualty and is able to pull the chest tight enough in order to hopefully pop that out, and not, so they say pop or drop. Okay. If your casualty does go unconscious, as soon as you're about a few minutes max without oxygen, your casualty or your person is going to go unconscious, right? So we do go on to the next steps of cardio, like for CPR. Okay. So the combination of chest compressions and ventilations is obviously designed because we need to circulate blood, introduce fresh oxygen, which may become a problem that if there is a full blockage that you're not going to get that oxygen in, because even if you're giving breaths and the air is not going in, all they are currently doing is working on the oxygen that's already in their bloodstream. Okay. So um, they do say about 100 to 120 compressions per minute, but it's about 2 compressions per second. Um, this is the adult rules. Okay. So you're going to deliver 30 compressions. They're going to be 5 to 6 centimeters deep. And then you're going to give 2 ventilations. So let's start at the beginning. So your compressions, 2 per second. Your 30 compressions should only take about 15 seconds, and you're going 5 to 6 centimeters deep on an adult, and you need to find the heart. You need to make sure that you're landmarking and doing those compressions on the heart. If you are anywhere else, we are not making progress. Okay. So, um, we wanna make sure that you're actually hitting the right spot. And then when you go to give your 2 ventilations, so again, head tilt, chin lift, because it opens up the airway, and so especially if the tongue has dropped to the back of the throat. Um, so you're gonna give those 2 ventilations, breath in, chest rise, chest fall, right? Because whatever you put in has to come back out, okay? Because we don't want the lungs to fill and then just sit there. We're trying to give them 2 effective breaths. So breath in, chest rise, chest fall. Breath in, chest rise, chest fall. When you go to give that breath, you're very likely going to be able to see the chest go up and down, okay? If the air is going in. Okay. So we do want to initiate and continue that until your casualty breathes again. You have another bystander that can come and help. Maybe one of you is giving breaths and the other one is doing compressions. Someone, a doctor, a paramedic, and I know rules are going to be different everywhere. We do actually have paramedics now that are allowed to, like, they'll be on the phone talking to somebody and giving out what all the stats and the rules are of what's popping up on the actual heart monitor screen. And they will be the ones that will tell you to start or stop. We here in Ontario aren't actually allowed to, like, I am not allowed to stop, like, not stop. I'm not allowed to stop unless told. Unless you're physically exhausted, help is not on its way, or everything else is happening, depending on your circumstances. Um, they will ask you. One of my coworkers, her mother went to check on the neighbor and called it in and said, my neighbor's sister has passed away in her sleep. She's not breathing, etc. And they said, have you started CPR? And she said, no. And she said, are you refusing? She's like, listen, I'm a nurse. I'm going to tell you how many hours ago this woman probably passed away. We're not doing CPR on this woman's body. This isn't going to happen. And so they do ask in here in Ontario, are you refusing? Because you're not supposed to refuse. But her being a nurse, she was like, no, we're not doing this. So um, the difference with just regular CPR and CPR for choking is that you're going to do your compressions and you're going to give your breaths, but every time you go to give a breath, you're going to look in the mouth to see if whatever was in there was dislodged, because we do not want to push it back in there with our breathing. Okay, we want to make sure that we are being effective and not causing more issues. Okay. If you happen to be lucky enough, an AED, I don't know what they cost in the States or even in the UK. Here in Ontario, they're about they are getting cheaper. They're about $2,500. So depending on what brand you got, you can, I think, find them on the internet a little cheaper. We are pretty fussy about whether this is a Zoll brand by the color, or whether it's a Philips. Stryker is coming out with one, which is starting to prove that it might be a little bit effective. So it is a device that will do a heart check, okay? And it only does a heart check. It's not like you see in the movies or on TV. It's not like they rub the paddles together, they stick the stickers on and it shocks. It doesn't do that. It does a heart read, and what happens is it will restore an abnormal rhythm. It cannot restart one. If they have a heart rate that's regular, it won't work. If they don't have one, it won't work. It's got a few reads. It knows it's running through the system what it picked up as information, and it will know whether or not it will shock. Even as a firefighter, and we get called out to med calls, it's not very often, and it's mostly because we see a lot of people not trained, especially in the seniors. They'll call because their spouse is on the floor or they didn't get up and get out of bed that day. And or they hear them fall, but they wait for first aid to arrive. And what ends up happening is, because from when that call went in to first aid actually arrived, it's a lot of minutes, and it doesn't seem like, it might not be a lot of minutes, but it's a lot of minutes in a life-saving situation. So if you do have an AED and you've started CPR and you're like, if you're going to have a heart attack, this is a terrible statistic, but if you're going to do it in Ontario, I don't know about everybody else, do it in a government building. Do it at an arena, do it at a library, do it at a pool, do it somewhere where there's actually the equipment that can save your life, or somebody else that knows first aid. Because the things that we're noticing is that, a lot of this, it's happening at home, and they haven't started CPR and they don't have AEDs, etc. And so when they give out the statistics of how to save a life, a lot of those statistics are because they didn't have CPR started, etc., right away. Anyway, so in order to use an AED, there are some special circumstances. Pregnant people who have pacemakers, surgery, medications like for a patch. You can only use an AED where it's dry. It is a battery. The back of an ambulance, even in the back of an ambulance, we have to stop and pull over in order for it to get a proper read. If you have an AED on and you're driving down the back of the road, um, it won't give you a proper read. It can't read the heart rate. Any metal surfaces, any body jewelry, etc. Okay. If you can open up the AED, turn it on. I put this picture in here mostly because if it does have an AED wherever you are, this is a Zoll. I call this the Z-shaped pad. So one always goes on the um, right shoulder. Is that right? Yeah, right shoulder, left side. Okay. And so you do have to bear the chest. And St. John, and I think it's the St. John in UK, did a huge campaign last year about how women are more likely to die over men because people will not open their shirt and put an AED on. So you need to follow the voice prompts, bear the chest, which it does include cutting off a bra. Um, Dry or shave the chest as needed. You do need to make sure it's dry. If they are sweaty or wet, etc., the pads won't stick, and then you've just rendered your AED pads useless. Okay. Always follow the instructions. This is a Zoll. It comes as a one piece. Phillips do not come as a one piece. They come as two separates. I will show you those in a different picture. The AED will analyze. Please remember that it will only work if it's got an abnormal heart rate. Nothing else matters. Follow the instructions. These ones are pretty smart. The automatic ones, not only does it tell you what to do, it will do it for you. It will give a shock, etc. Okay. So regardless of the type of the machine, you just want to follow them step by step. Okay. Moving on to a child that's choking, your signs and symptoms are a lot of the same, but your symptoms of what your signs of what you see might be a little bit different. They do talk about kids with a little bit glossy eyes, or they look like they got the big wide open eyes because they know that they're choking, but they're not actually sure what to do. So they might be able to cough and make some noise. They're going to be in a panic state. If it's a severe blockage, there'll be no coughing, no noise, blue face, wide eyes. Okay. So it's very similar to an adult. Reduced intensity. Obviously, we still want to give back blows, obviously, not as hard as an adult. Okay. Abdominal thrusts are also not as hard. And you may have to, depending on the size of the child. And this is why they kind of gave you the age range of a child between 1 and 8 years old. Because if they actually did what a child was, 1 to 16, your child that's 2 versus 15 are not going to require, again, the same back blows, right? So you are giving them per physical body type. Okay, and your compressions may not be as deep. You're going about 1/3 to half of the depth of the chest. So maximum 5 to 6 centimeters, where an adult's 5 to 6. You may not be doing this as deep. Okay, and you may have to modify. You may have to get down on the ground for a smaller child, depending on their body type, etc. Wheelchair rules are going to kind of stay the same. Do they have the head support? What is their strength? Can they hold their head up? How are we assisting them? And what is the best for um, whoever our current casualty is? Okay. So again, it's very identical. Again, 30 compressions. Okay. When you are giving compressions on an adult, um, everybody's like, "Woo!" The first 2 minutes is okay. It's tiring. It's okay. But again, the more we do compressions, the more tired we become. So we want to make sure that when we're giving those compressions, that we are doing the best for both of us. So adults, over top, straight arms if they're on the floor, giving those 30 compressions. Child, again, depending on the size of your physical child. This picture shows one hand on the middle of the chest, whereas um, the more you go and the more tired that you get, you may need to bring in a different hand, switch hands, making sure, but you're using not just your arm strength, you're using your body strength. Okay. Your rate still stays the same. Now, your breaths are going to change. You're still giving 2 breaths, but remember, these humans have smaller lungs. So when we go to give those breaths, we're not if we put too much lung or too much air into someone's lungs, it goes into their stomach. And what happens when we have too much air in our stomachs? Well, conscious people burp. Unconscious people don't burp, right? So we need to make sure that you're seeing just the chest rise, chest fall, and that you're not putting air into everywhere, because they will throw up the stomach contents while you are giving them CPR. Okay, so here we go with our differences using 1 or 2 hands depending on the casualty size. Your depth of compressions is 1/3 to half of the depth of the chest, and the volume of air delivered is less, but not and only still chest rise, chest fall. Okay, now I only put this one here because child and infant are the same when you have an AED. Okay, we didn't need to review it twice because we're going to go to infants next. Okay. So child and infant AED. So the protocol is the same. So you follow all the steps of your AED, follow the directions. The exception is that you need to place the pads, one over the heart and one under the heart. So with an adult, they're going here and here, and the shock is going this way. With these ones, because the child is smaller, they can actually go one on the front and one on the back. Okay. So, if they are touching, they can't have them touching, overlapping. So, pediatric pads, pediatric setting, every AED is different. With a Zoll, it has different pads. Okay. With something like a Phillips, when you open up the Phillips, there's a little key inside of it, and you actually have to turn the AED to child. They're all different. If you work somewhere or there's a children's center that you take your kids to, or now your adults, it doesn't hurt, for our own peace of mind, to see what they do have in an AED cabinet and go home and watch a few-minute video. Our biggest help is definitely knowledge at this point. And if you are going to the hospital, and you pass it on the way to the appointment, figuring out what they have and watching the video on it would definitely help. Okay. Now, if they don't have child pads and you have to use an adult pad, I'll go back to this one for a sec. Okay, so if you look at the way that the gray touches the blue on this picture, those pads actually perforate. They actually come apart. So if you had to use them as child pads, one could still go on the front and one could go on the back. If you don't have them, something is better than nothing. Okay. So this one is our infant. So their airway is much smaller, so that's going to change also our lung, like our breath size that we're giving them. So an infant's airway is very small and approximately about half the size of their finger. Okay, so as a result, it makes it easier for them to choke on buttons and food, balloons, toys, all of those things. Okay. Again, same as everybody else, mild. They can still make some noise. They're crying or they're breathing. We're trying to, you can't, and we do talk about this in the adult. It always says try and encourage them to cough. Can you cough that up? Do you need help? What are you like? All of those things. So when you notice an infant coughing, we want to start coughing and hope that they mimic what we're doing, because they're not going to understand the words cough. Okay, so the casualty cannot cough or breathe when it becomes severe. They will look like they're trying to cry, but without any sound. I know family members are scary because I've had to do a lot of this on poor little Natalie. She had some apple pieces. Um, so you want to place the infant on your hand face down over your forearm. Okay. Um, Head is lower than the hips. Again, hoping gravity is your friend and that the item will dislodge itself. Okay. Now she's going to support that head. This is where we're talking about the support to make sure that this is still supported, whether they're infant or they don't have the strength to do that in their chair anymore. Um, Definitely having that. So she's got the baby on the whole arm, and its head is lower than its hips. She's going to take that baby and she's going to flip it over and tuck it in, and she's going to do chest compressions. Okay, chest. We're not doing abdominal on an infant. This is now chest. Okay, so she's now put the baby into this arm, legs on either side of the arm again. She's tucked it in and she's giving. But remember, we also have to make sure that we are doing this on a stable surface because I see people, they're out here and this is not effective. Okay. So whether you're sitting and your arm is now on your knee, some people will get down onto the floor again, depending if you can do it. It's an infant. You can carry it with you, right? Go meet whoever, the paramedics or somebody at the door. You can, but again, you still have to make sure that you're being effective, um, and making sure that you are on a solid surface while you are doing this. Okay. So using 2 fingers on the breastbone just below the nipple line, okay, that little center of a chest. After this, we no longer use the nipple line because we know as we all grow and change, that theory goes out the window. Okay, so we want to push 1/3 to half the depth of the chest. Um, Depending on the size of your infant. So when we were back doing CPR, when we talk about giving the 2 breaths, we didn't talk about this enough. Head tilt, chin lift, you go to give your breaths, you need to make sure that the nose is plugged. Okay. Because if you do not plug the nose, the air is going to go in and it's very likely going to come back out of the nose. So children and adults, head tilt, chin lift, plug nose, give breath, chest rise, chest fall. Infants, you have 2 options. You can do depending on the size of the infant. Um, if an infant, remember, is under the age of 1, head tilt, chin lift, plug nose, give little breaths, like their lungs are like the size of our cheeks. That's really all you need to give them because we don't want to overinflate their lungs, especially at this age, and cause damage. Um, if they're much littler, you can use your mouth to seal over the nose and mouth when giving breaths. So we provide the 2 small breaths just until the chest rises. Chest rise, chest fall. Okay. If they are, when we're doing the back blow, 5 back blows, we're still not hitting as hard as we were. And then when we do the flip over, 5 compressions, they go unconscious. This is where we perform CPR. So we'll talk about CPR um, as a life-saving measure, but also when you come from the choking position, again, every time you go to give breaths, every round, you want to make sure that you're checking the mouth because if you can push this out with the chest, then you don't want to blow it back in. Okay. So your compressions are at least 1/3 of the depth of the chest, right? No more, no less. Making sure that you're landmarking, you're finding the right spot for all of these chest compressions because we want to be effective. We did have a call. Um, the doctor chatted with me afterwards, not with my family, but with the fire department, and we did talk about the effective, the sweet spot, making sure that you are doing the right depth at the right speed in the right position all of those things. And also people, and I've noticed this, I do love the guys that I work with. I'm not going to lie, but they're like, "Oh no, I got this. I can do another round." If you're getting tired or slightly getting tired, having somebody step in is not a terrible thing. It is a it might be a pride thing to you, but really honestly, doing the best for your casualty and making sure I do 2 minutes, he does 2 minutes, I do 2 minutes, he does 2 minutes. It gives you that little bit of a moment to have that little rest in between instead of continuously. It is hard work. 2 minutes of CPR is a lot of hard work, but so is, 20 minutes, because if that's the heart rate monitor is starting to show you that you're making some leeway, etc., you want to make sure that you're not doing that, taking one for the team and doing it all by yourself, because not only have they proved that some people are not physically fit to do it for that long, they can give themselves a heart attack, you're not actually beneficial for the patient either. Okay. Oh, I did throw it in here. There you go. Your infant AED. Turn it on. Follow the voice prompts again. Pads for an infant will always be front and back. Okay. So, it is a lot to learn in that little bit of time, because normally in class that takes hours, where you'll get the hands on and you understand how to go and do a lot of that. This will never replace your hands on. Our WSIB rule, so that's our workers board of insurance or something, they do say in order to pass, because people call, "Can't I just do this online?" No, you absolutely cannot just do this online. You need to come into class. You need to landmark. You need to show an instructor that you can actually do the compressions at the right speed. When we do those compressions, we have people, some of the guys, like they're almost too strong. When you go to do your compressions, the heart always has to recoil. Our hearts beat. And so if you get to the point where you've pushed so hard on the chest and you don't let the heart come back up, you're just holding it in a holding pattern, and that's not helping either. So the recoil is at the right speed and the right depth. So when we talk about the depth going all the way down, you do have to make sure it comes all the way back up, or it's not being effective. Okay. So moving on to a little bit of wound care. There's not a whole lot in um, this protocol, and I say that because we're a first response, right? We're the ones that are like first on scene. We're the ones that we stop the bleeding. We're not generally around for in the infection part. And so wound care is also when you go and the incident has happened, we're going to do all the things that prevent wounds from being infected, right? So we want to make sure that we're taking the proper first aid so that we do not cause an infection. So that's what our line of defense would be, is basically you got your gloves, you got your hand sanitizer. Here's some of the wounds that we have, you know, bruises, scrapes, laceration. So that would be your cut, but then your incision is your straight cut. Your puncture could be anything from um anything that enters the skin right down to a sliver, right? Making sure that we're treating that and keeping it clean, your avulsion and amputation. So how do we reduce the risk of infection? And I know that our world is a little bit different, whereas like, AFOs that cause pressure sores, or sitting in a wheelchair too long, where we've had to get to the point where you're making sure that you don't have those chair sores or those bed sores. And what can we do? That's also communication, right? Are people finding that, our symptoms are, my butt is really sore today. And so we've had to go above and beyond. Seating wasn't ready for us yet, and you have to go sit on an extra pillow every once in a while. It is what it is, but you're trying to prevent. Prevent is our number one key at this point. So how do we reduce the risk of infection if we do find an open sore? Keeping the wound clean using water, or whatever is prescribed medication, etc. Wearing your PPE, hand washing, making sure that the wound is kept clean, and covered antiseptics, again, depending on your local regulations of what you're allowed to use. Um, we'll start to notice not always just at the sore, and most of us will know some of these things. um, the wound becomes infected, it can swell, it can give off heat, it will start to be sore, it can be red, it can produce pus. I think one of the other biggest things is that when you start to get, or no one's noticed, when the body starts to fever or is trying to fight off some sort of bacterial infection, etc. Noticing those signs and symptoms, and whether or not they notice, um, will notice you're off, you feel warm, or, depending on what the infection might be. Okay. Nosebleeds. I'm not sure how many of the kiddos, if they're on oxygen or any of those kind of things, but we do know that nosebleeds can happen caused by dry nasal passages or trauma. Okay. If the infection, or if the nosebleed is from um, an occurrence. Like, I used to be a lifeguard as well. So, you get a lot of kids swim lessons, and they're blowing their bubbles, and all the air is coming out of their nose. So we'd end up with kids that would have bloody noses just from blowing and doing swim lessons. That's not what we call trauma, right? You get them up, you get them out of the pool, tilt the head forwards, because we do not want everything running down the lungs. We want to make sure that it is coming out. The other thing about when it does come out onto a Kleenex like this, we think that that's not a lot of blood. The average adult has about 4 to 5 liters of blood. We need mostly 4 of those to function. The loss of 1 liter of blood can be detrimental to the system, because now all of a sudden, if it's not pumping to the brain properly, we're now looking at low blood pressure. We're looking at incidents that will not really be great, and they can cause you like spills, trips, and falls, because you're not getting enough oxygen to the brain, right? If it is trauma induced, they fall out of the wheelchair. Or I remember when Natalie's dad was carrying her up the stairs, and one of the boards broke and they went through, and she had a little tiny nosebleed, but mostly we thought that maybe she had fractured, or broke a leg, because they went right through. So keep an eye on how many Kleenexes you use. If the nosebleed doesn't stop within like 4 to 5 minutes or up to 10, you definitely need to go seek medical help. Don't blow your nose, right? So we're tipping the head forward, we're pinching the soft part. You're sitting upright. If you can, lean their head forward. Continue to hold that. And again, avoid blowing your nose or putting anything in your nose for several hours. I don't know what we're recommending not putting up there, but just let's not. And you're going to cause more issues, right? Because I think they do have like nasal masks and stuff where you can put um, like some sort of hydration in there so that you don't get that dehydration. Okay. Um, Again, if it's still free flowing for 10 minutes or even after pressure, you want to get in there. It doesn't look like a lot of blood, but we've learned that it's a lot of blood. If the result is an injury because of trauma, head trauma, any of those things, you definitely want to go seek medical help. Maybe things aren't where they belong, right? So interferes with their breathing, or children under 2 years old, because they definitely do not have 4 to 5 liters of blood. So depending on your physical size, the smaller you are, because the average adult has 4 to 5 liters. What would that be in? I'm trying to decide American right now. Uh, yeah. So when you go to the store and buy a jug of milk, I know here in Ontario we get 3 bags. That's 4 liters. So I guess that would be like 4,000 milliliters. I'm trying to do a little bit of math here. It's not quite. Yeah. Anyway, watch how much blood you lose. So, the next thing we're going to talk about is like fractures, dislocations, sprains, and strains. We are not allowed to diagnose somebody's injuries here in Ontario due to liability. Um, I recently tried to diagnose my own and I was completely and utterly wrong. And now it's only a finger. However, it's probably going to be deformed for the rest of my life. So let's making sure that if we need medical help, again, depending on your situation, um, you want to try and get help. Natalie and her brother were fooling around she was sitting in a chair. She'd come out of her wheelchair and she was sitting in the rocker recliner because she would sit on a different seat. And she had fallen over on the chair. And he decided to do what I do, and he went to sit her back up, but he pulled her right out of the chair, and, she pretended it didn't hurt, and in fact had, um, fractured her femur. And so, off to the doctors we went and got it. Now, there are different, things about it. So sometimes, depending on the severity, um, it's generally a closed fracture. But if does become an open fracture where the skin is broken, obviously we're going to start to see a lot more problems. It can lead to infection, all of those kind of things, dislocation, where joints aren't in the proper contact. And I know, especially with spinal muscular atrophy, their muscles aren't as strong. And maybe it's easier for them to pop out, sprain and strain, not as common, but can still happen. Oh, are you ready to stop me? It's 3 o'clock already. Is that what you're
Well,
waiting for?
that's okay. How is everybody doing for time? This is fabulous, fabulous information. In fact, our son Aiden has had dislocations, etc. too. When you're in a wheelchair, your
Mhm.
muscle tone is low. I understand if people do have to leave because it was for an hour, but I we'll definitely keep this going. And it is recorded. So, but I'm finding this very fascinating and it is really, really, reasonable to have our community be affected by most, if not all of these items. So if you have the
Okay.
time,
Well, I do have,
Christina,
I think there might be another 10 slides.
perfect,
Not
perfect.
quite sure, but there's a few more.
Okay.
Okay, so I have no problems. I'll continue. So there is again, we can't diagnose, and obviously we're not, we don't have the skill of, realizing what's actually happening because we can't see that. So we want to do make sure that we get proper medical care because what you don't fix today may be a problem tomorrow, right? So, recognizing bone and joint injuries, swelling, bruising, they no longer want to use the limb. They may not want to tell or may not be able to communicate that. And then you'll start to notice when something happens, we start to make up for it by using the other arm or the other arm or the other, however we can in order to, regular everyday life, right? Pain, local tenderness, shock might be a thing. Everybody, the first thing we've noticed is people get up and they're like, no, 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 I'm fine. It's all good. Like, and you can tell that something isn't right. And especially if it's traumatic, making sure that the casualty stays down and that they're not trying to get up and move around because they can cause more damage. Although that's what our normal life would tell us is to just get up and walk it off. Because I remember, when our parents used to, "You'll be fine, just walk it off." Don't do that. That's no longer a medical rule, right? So we do want to use the word rice. Try and rest. We don't want it to swell up. We definitely need to immobilize if we're transporting the casualty, something like a broken rib or etc. The more you transport, the more they bounce around. That's what we found with Natalie's femur. You're trying to not cause any more issues. Cold. You can put cold on for 10 or 15 minutes on and 10 or 15 minutes off. Only if it's a closed injury. Do not put ice on a bone sticking out. Obviously, they're not going to probably let you anyway. However, that's a general rule we do have to share. We do recommend if you can elevate it. Again, it does help reduce the swelling. Um, you can put that on 10, 15 minutes on again, and never directly on the skin, right? We want to make sure that that's protection, because if you put it on the skin, then all of a sudden you're looking at causing frostbite, and we don't want to cause more problems. Okay. Another one, a good topic, especially in younger children, or sometimes our peeps get a lot of medication. So preventing any sort of poisonings. We want to make sure that we're not causing illness or death, because again, um, you're if you read the prescription wrong, and too much may be too much, right? So some substances only require a small amount to be poisonous, whereas other substances require more like sizable dose or prolonged exposure. Okay, um, depending again on your physical size. One of the biggest things, and I don't know because everybody else is American or in the UK, I don't know what your rules are, but here in Ontario, we have made weed legal. And it's not a bad thing. People are going to use it anyway. That's a whole other conversation. But the first little bit, they were finding that, they make weed cookies, and kids were finding cookies and eating them. And so what you could eat a quarter of, like a nibble in a child, can be very toxic. Okay. So making sure that when you have substances of any kind, that they're definitely locked away. Okay. Because our routes of entry are swallowed, inhaled, absorbed through the skin, or injected through the skin. Again, depending on what or how the medication is taken. Now, if someone is coming into your house, or you again are helping somebody with the medication, we do talk about how the medication has to, requirements are met, right? So it is the right amount. With the right medication and the right person, the right method, the right time, the right documentation, and depending on who your patient is, they may have the right to refuse the medication here in Ontario. It just depends on what it is, who it is. Um, we do have a Good Samaritan law. Like if someone has taken too much fentanyl, and they're unconscious, they don't really have the right to refuse. They get Narcan. um, but if someone, is having a heart attack, I have aspirin on my keychain, and I say, like, I have aspirin. They have the right to A, not believe that it's aspirin, or B, they'd be like, no, I'm not having a heart attack, right? So again, it kind of might depend on all of those other rules. Okay. Uh, Liability is a thing. Make sure that you are following rules as to what is beneficial for everybody else, but also yourself. Okay. So, health is a state, again, of complete physical, mental, and social well being, not merely the absence of disease or infirmity. See, here's the thing is that as a firefighter, I'll tell this little story. We had a rooming house burn down here in town. Marla may know about it, but we had 44 people who lived in this rooming house, and 44 people now displaced. And socially, most people, it's a rooming house, so they don't pay a lot of rent. It's probably, the rules, or like the stigma that comes with it of living in a room, like a rooming house. Yes, sometimes there are drugs there. Not everybody in that house was a druggie. All of those kind of things. And so there is a lot of stigma that comes with it. So we need to make sure that we are looking after people's physical, mental, and social well-being. Okay. Not just merely the absence. And one of the biggest things I think that happens is when people have something happen to them, especially traumatic, one of the biggest things that goes through their mind is, am I going to die? And so you're not just treating somebody physically, you're also treating them mentally. Because remember what we're talking about earlier is that we always want to make sure that whether they're conscious or semi conscious or unconscious, help is on the way. We always want to rest and reassure. We always want to tell everybody that it's going to be okay, even if we're not sure that it is, right? Because if we tell them that it's not going to be okay, that's really not good for somebody's mental health. So it is the capacity of each of us and all of us to feel, think, and act in ways that enhance our ability to enjoy life and deal with the challenges that we do face. Okay. Hopefully, it's a positive sense of emotional and spiritual well being, respects the importance of culture, equality, social justice, interconnections, and personal dignity. And that's one of the things that I think we're really trying to work here with the Public Health Agency of Canada is that just because I'm a firefighter and I'm there to put your rooming house out of like out of the fire out doesn't mean that you're not a human with housing needs, etc. Right? So there are life events that cause stressors. Witness to a traumatic event. We call it a normal reaction to an abnormal event, and so whether I see a lot, and so to me it's kind of like, oh, that happened, whereas just because that I'm used to it doesn't mean that everybody else should be either, right? And we talk about the birth of a new baby and the hormones, death or illness in the family, recent job loss, especially if it wasn't your choice. The things that happen, people are like, how am I going to go home and tell my spouse? um, drug drug abuse or dependence of any sort, and we call that self-medicating. Um, People will not go seek medical help, but they will go and try and go home at the end of the day and have a glass or two, or what they call drowning their sorrows. Okay. So anyone can be of comfort to someone having a mental health problem or injury. As human beings, we want to fix problems, most of us, right? Um, People making them heard is the most important thing. And I know as one of those parents with a child with disability, I do remember, and still to this day, Natalie's life expectancy at the very beginning, our pediatric doctor was like her teenage years to her 20s. And so now people ask me, how is Natalie doing? And she's not doing great. She's on her fifth eating tube. She's been struggling for the last year. And they're like, oh, well, that's good because they thought she might be gone by now. And I was like, I'm not sure if that's the thing that how do we as a society, we want to have those conversations, but what is the actual answer? But with all of that, like we spend a lot of time and a lot of hours looking after everybody else, but we do have to remember that we do need to look at after ourselves too, because if we are emotionally spent or physically spent, etc., we're not any good to the people that need us, everybody. And I know that's hard for some. It took me a lot of years to finally be okay, how do we get here? So what is it that we want to do to take care of ourselves, right? So um I don't know if just like and watch the video. It's a Brene Brown video, and she talks about how they come and they say, Sarah's being kicked out of school, or so and so, maybe her brother has really good grades. And I think the thing about this video is that as a parent with special needs, I think one of the biggest things is when people want to have a conversation with us, they want to point out the good when maybe they've asked and things aren't as great as we want them to be. Right. So Brene Brown does talk about that. Do I know how to answer on the mental health portion of how to answer everybody back? No. But she does have some great videos, but I wasn't quite sure how long this would all take. So thank you everybody for hanging in today. And thank you for having me. That's kind of how I wanted to end it, but I will send the link to you, Marla, and then you can, for those who haven't seen it, can go check out the video.
Absolutely. Thank you so much, Christina. That is like a wonderful, wonderful
Oh,
presentation.
of
I know there's one thing that I don't know if it was dealt with, and I don't think I saw it, was seizures. So
Yeah,
our
that's one I
our
didn't get to. Yeah.
I know there was so much information. So if you just want to take a brief moment as to what to do if somebody is experiencing a seizure.
Yeah. So one of the biggest things that we've learned is, again, it's going to really depend on your type of seizure. So we're learning a lot more about them. And, back in the day, one of the biggest things they used to do was all of a sudden try and get a wallet into somebody's mouth, and we don't do those things anymore. So your seizures are going to depend on your child and your situation. um, so Cerebral seizure is like when your children are still in the infant stage, and they're experiencing temperatures that are too high, and we're trying to cool them down. So whether that would be washcloths, etc., until medical help can arrive. All of the medical situations that I generally talk about, please call 911. I haven't met anybody yet that can drive and perform CPR. So the whole medical situation of people, and I get it, especially if you're American at this point. Um, I know here in Ontario, we're very lucky. Like, an ambulance ride for us is, I don't know, somewhere around $50. And so, um, yeah, I know not everybody has that luxury, but I still also haven't met anybody that can do CPR and drive. So, having medical help show up again when the situation is a lot. Seizures, you want to try and definitely, if it's cerebral and they're an infant, you're trying to cool down the body. If they're older, again, rules change as per family, and I say that because, depending on if it's your first seizure, you're definitely going to seek medical help because you're not sure how long they've been without medication or without oxygen, and that's gonna start your process into figuring out if this is a first seizure or if it's going to be continuously ongoing. After that, I used to teach all the special different ability children at the pool, and the EAs would come out and they're like, okay, this is Nick, and he has seizures every once in a while. He's getting to the age where he can kind of tell where they're coming on. And he would start to know those things. And, if you're in the pool, here's what you need to do. They You need to make sure that they're somewhere safe. You need to make sure that you've moved the furniture, making sure medical help is on the way. When I worked at the pool and we had the children that they had rules. They knew that they could have seizures, and then the rules were like within like a minute they weren't calling for medical help as long as they would come back out of it. Or we, as soon as someone would have a seizure, we would get a stopwatch. Obviously nowadays everybody's got one of those on their phone. Start timing how long the seizure is lasting, because that is medical information that the doctor's office will want to know. And making sure. So we had a rule because the EAs would tell us, "Oh no, so and so can go. Their seizures usually last about this long, and then it takes them a little bit to come out of them." We had a rule like after 3 minutes, if you're still seizing, you're going to medical help because that's beyond our capacity. Um, so we do have the seizures where you do see the body start to move, but they're starting to see. We had one girl that would have blank seizures, and sometimes you couldn't catch on right away, but eventually you would, because all of a sudden she was flat as a board. She would never move. So what everybody thinks is a seizure and what they're starting to define as a seizure is completely different. So again, start to look for signs and symptoms. Are they moving? Make sure the furniture is moved. If you can support their head, making sure that they're not hitting their head off the floor. If there is any of that that's happened, or they have fallen on the way down to a seizure or fainting, you want to make sure that if they've hit their head injuries bleed twice as much as anything else for some reason. That's just the way it goes. So if you do have a head injury, you're more likely to lose about twice as much as blood. And making sure that you do support them, making sure how long have they been without air. If they are looking like they're in like a blank seizure, you still got to look for signs and symptoms. What color is their skin? Is it regular, pale? Are their lips blue? All of the things that you want to make sure that are giving you signs that they are out of oxygen. And some people will already know, like, what the rules and, signs and symptoms are for how long their child is allowed to seize before they call for medical help. We have had, as a fire call, we actually responded to a man having a seizure, and, by the time we got there, he was no longer seizing, but he was very unconscious, not responsive. So we did end up having to take him to the hospital because, his ex-wife, he was visiting the kids. His ex-wife called and said he's never had a seizure this long. So just because we're also used to them happening 1 minute, 1 minute, 1 minute also doesn't mean that they're going to change, right? So monitoring signs and symptoms. Some kids will come out of it, some people will come out of it, but start to notice if there's anything different. And those will be the ones that will catch you because, right? It's like the boy who cried wolf. All of a sudden you have a seizure that's abnormal than what has normally happened. Yeah.
Wonderful. Yes. Thank you again, Christina. Does anybody have any
Problem.
specific questions they would like to ask? Everybody's different in our leukodystrophy world, so maybe you have a specific need that you want while we have Christina here.
I think that's one of the things too with SMA. So there's 4 different types of SMA. So type 1, type 2, type 3, type 4, and much again like how your onset happens, how your deterioration happens, all of those kind of things. And again, we're like, I think it's like 1 in 40 people in the world carry the gene, and it takes 2 people like Natalie's dad and I to get together and have a Natalie. And the numbers are just, again, like, you guys are so rare. Most children with SMA actually, the statistic when Natalie was diagnosed was they didn't make it past their second birthdays. But then back then they weren't doing feeding tubes and tracheotomies, and now we have $1 million med on the market right now. Um, and so, but if anyone has any questions, so I'll send out a few things. I'll send an email to Marla. I will send my obviously she'll have my email. And then I will send out the link to the video that I hope everybody will go watch because self-care is very important. And then number 3 would be we do have a QR code for our Ontario St. John ambulance book. And then you can download the whole thing. And at any time you want to go and have a peek through that, you can go down, like, all the things that I've talked about will be in the online version of the book.
Wonderful.
Sounds great.
Wonderful. And I will be in touch with you, all of you who have been able to make it on, and even some registrants that were not able to make it on. I will be in touch with them. And this will be posted at some point when we have it down the road. This will be posted on the ULF website as well. And maybe we can insert those links in there too.
That was
Yeah,
great. Thank you
absolutely.
so much.
Not a problem at
Excellent.
all.
Like I
Thank
said,
you
when
all
I
for
had to leave,
joining us.
I had to deal with children real quick.
No
Yes,
worries.
they
Well,
happen.
thank you. Yes. Thank you, everybody, for joining us this afternoon, evening, wherever you are. And I hope you found this useful. Cheers to all.